Rather than engage in all of the etiologies of potassium, what you need to know as a third and fourth year clerkship student, I want to start dealing with what you actually need to do and some of the nuances of potassium repletion and potassium lowering in a patient who has too much or too little potassium. The thing about potassium is that it's got a very narrow normal range. At its broadest, 3.5 to 5.5. Most of the time, it's 4 to 5. I'm making a big deal about that range because you don't have a lot of room to play. And if you wait too long, what's going to happen is a fatal arrhythmia. So first, let's start off with hypokalemia, what you're going to do to replace the potassium before an arrhythmia sets in. The pathophysiology really isn't that important because it's not what you're going to be doing. When you find hypokalemia, what you're worried about is a fatal arrhythmia. And so you want to replace it. This is something you're going to do basically every day because patients who are in the hospital, we keep them NPO, we give them fluids, we're going to cause the potassium to either replete or deplete. And so you have to every morning make sure that their potassium is normal, as long as you're checking those BMPs. But to replace potassium, you simply give it IV or PO. And in general, 10 milliequivalents of potassium changes the measured potassium by 0.1, which is convenient, 10 to 0.1. But this is only in the case where the potassium is greater than 3, which means that if your potassium is 3 and your goal is 4, in a single 24-hour period, you would have to give 10 times 10, 100 milliequivalents of potassium. Some nuances here. If you're going to replace it IV and all you have is a peripheral IV, potassium burns, so you cannot replete faster than 10 milliequivalents per hour through a peripheral IV. If you have a central line, you ignore that burning sensation, but have to be worried about delivering potassium directly to the heart, knowing that that's how we kill people in capital punishment. So you cannot go faster than 20 milliequivalents per hour through a central line. And so if you were dealing with someone on the floor, they didn't have central access and they couldn't take anything PO, to get from 3 to 4 would take 100 milliequivalents at 10 milliequivalents per hour, which is about 10 hours. That's not that bad. You're able to do that. The problem is when you get below 3, you require more milliequivalents to move it that 0.1. That is, in order to move 0.1, you need 15 milliequivalents of potassium chloride when the K is between 2.5 and 3, which means that to move from 2.5 to 3 requires 5 times 15, about 65 milliequivalents. So now, if you're going to replace from 2.5 to 4, it requires 165 milliequivalents. It's going to take about 16 hours. If it gets any lower and the patient is still alive, it takes 20 milliequivalents of potassium chloride to get the K from 2 to 2.5. Which means that if you're going to go from 2 to 2.5, it's 5 times 2, 100 milliequivalents. So if you waited to allow the potassium to be 2, to replace that in a day would take 265 milliequivalents, more than 24 milliequivalents, more than 24 hours through a peripheral IV. The point being that you need to catch low potassium early and replace it quickly. The best way to replace potassium is PO, and you can do it with 40 milliequivalent intervals. The 6 is an arbitrary number. That is to say, you have them either take elixir or pills every 4 hours. The IV guarantees it will be in their system, but you can't overshoot because you might cause a cardiac arrhythmia just by repletion. But in a patient who can tolerate PO, you can give an awful lot. 6 times Q4 is 24 hours. You get in 240 milliequivalents PO in a day. In addition to the IV supplementation, you won't have any trouble catching up. The problem is in the patient who's in the ICU who you keep watching and don't replace the potassium. The point of all of this is that it's very crucial to replace the potassium when you start to see it go below 4. Why? It stabilizes the cardiac membrane, it prevents cardiac arrhythmias, and you don't want to fall behind. This is an easy thing to fix, and it feels very satisfying because you're writing orders and you are saving a patient's life. With critical hypokalemia, that is, there already is an arrhythmia, that is an electrolyte disturbance, and you go straight to dialysis. Which is the cool thing about any electrolyte disturbance. If it is critical and the patient is going to die, you can simply put a quentin in and have them dialyzed. Remember that for any electrolyte abnormality. That's hypo-K, and it's really all you need to know. If it's low, replace it. In hyperkalemia, it's a little different because hyperkalemia goes through a series of phases. The big thing with hyper-K is you're going to look at the EKG. As the K goes up, everything gets spaced out and pulled up. The normal EKG shows a P wave for the PR interval, a narrow QRS complex, and a T wave. Early changes of hyperkalemia are going to show a normal QRS complex with peaking T waves. You see peaked T's in hyper-K, you intervene. What's going to happen is that these things are going to get stretched out. So you can imagine that a little fisherman hooks a hook into the T wave and starts reeling it in. And what happens first is that T wave gets pulled up. And then as it gets closer and closer, it starts to stretch out. And eventually the person will go into a cardiac arrest with a sine wave. This is too late. You're probably not going to fix this person because you don't have time to fix the K with them in cardiac arrest. You want to catch it before they start to prolong their QRS complex or drop into a heart block. You want to catch it at the peaked T's. It's hard to bring someone back after this. You can, but it's difficult. So again, it's not about what caused the hyper-K. When you see it, you don't care. You've got peak T waves, you need to fix it. How do you fix hyperkalemia? There are 3 phases to the correction. Stabilizing the cardiac membrane, temporizing the K, and eliminating the K. You stabilize the cardiac membrane with IV calcium. You see peak T, IV calcium chloride. Calcium chloride is going to counteract the effects of the potassium. You don't have to remember the action potential equations or the phases. Just know that IV calcium is what you do if you see peak T waves. That doesn't last very long, so now you have to get the K out of the serum. How you do that is by shifting the K into the cells. You can do that in a number of ways. The first is insulin. And because you're giving the person insulin they don't need, you don't want to cause hypoglycemia, so you give them D50. The insulin causes a K shift into the cells. You can also use sodium bicarbonate by creating an alkalotic environment in the blood. The cells are going to give up some protons, some H+, to buffer out the sodium bicarb, and they have to stay electroneutral, so they take some K with them into the cells. Insulin D50 and sodium bicarbonate are usually the therapies of choice, but you can also use beta agonists, like an albuterol inhaler. This one not used so much. These used more often. But eventually you have to get rid of the K, because once these wear off, the K is going to come right back into the serum. So to reduce total body potassium, there's two ways to get it out of the body. That's in the urine and in the stool. And chances are, if their K is really high, their kidneys are messed up. If they're not, you can use furosemide. But chances are this won't be an option because of renal failure. Instead, you have to use K-exolate. All right, this was a quick one. The whole purpose of this lecture is to show you that the etiology doesn't matter. When you are confronted with either hypo or hyperkalemia, the goal is to fix it. With hypokalemia, you replete the potassium. As an aside, if you have trouble replacing the potassium, take a look at the MAG. You need MAG first. Or you have some etiology which prevents the potassium from being retained or absorbed. In hyperkalemia, you want to give them IV calcium chloride to stabilize the membrane, sodium bicarb, insulin D50 to shift the potassium into the cells while you get rid of it with furosemide and K-exolate. In any condition where the potassium is causing a critical illness, in particular an arrhythmia, if you don't have time to temporize, just dialyze, recognizing that electrolyte abnormalities is one of the primary indications for hemodialysis. That is potassium. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.